Two, I just spoke to Dr. Meski, who who is trying to join. Oh my gosh, this is her now. Okay, look, this is smooth. She says, "Any minute now. It's any minute now." Yes.
Yes, we did it.
We did it. This is amazing.
Yeah.
I adore you for talking to us today. Thank you. I know you're in clinic and it's always busy.
Yes.
Has it been a busy day so far?
Yes, I mean the usual. I just did a transfer. That's why I'm a little bit late because I had to change and try to look good for this Instagram live.
Not only
And
do you look good, you are helping create life. I mean, what a woman.
well,
I should introduce you. Dr. Meski from IVF Life in Spain.
yes, exactly.
Yes, good.
So
Looking forward to
I'm a specialist in genetics and fertility. I've been working in this field for almost 7 years now, and with IVF Life for 3 years. And I really enjoy this job. As you said, well, usually doctors save lives, and in this particular field, we help create one. So it's really rewarding when it works, of course. When it doesn't, well, it's also frustrating for us as well as for the patients.
Yeah.
But we try to do our best to help them. And
Well,
yeah.
I've got so many questions for you today because we're going to talk about fresh versus frozen. But
Yes.
can I just touch on the fact that you just did an embryo transfer? How does that feel? Like, how do you feel when you're doing transfers?
Well, of course, you have to go thinking that it's gonna work and that the next step is having the good news of the pregnancy test. So before doing the transfer, we always talk to the embryologist, see how the embryo is, how it's developed, and especially in this case, it was a frozen embryo transfer. So we had to see how the thawing process went, and then we go to the patient and we inform her. And of course, we're always excited. The patients are very well. There are different kind of patients. Some of them are very excited. Some of them are very nervous.
Yeah.
Some of them are just after several transfers, they already know the routine and they already know where to go and how to do all the preparation.
Yeah.
And then once we do the embryo transfer, we never know exactly how the catheter is going to enter the uterus cavity. How I mean, we always discover a little bit the embryo and the transfer at the same time. And then once we leave the embryo inside the cavity, it's always emotional. The patients sometimes they just hold hands with their partners or they cry or well, it's very touching. So we try to be there for them and that's it. And that's our job.
Beautiful. I just remember after my embryo transfer, not wanting
Yeah,
to stand up. I didn't want to go to the toilet. I
I
just didn't
know.
move.
Yes, most of the patients think that too. When actually when we finish the transfer, we always tell them because they're in the gynecological position. So we always tell them, okay, you can go a little bit up and get comfortable in the bed. Say they don't want to move even for that. They just want to stay right there. And I say,
Yeah.
it's okay, you can move.
Yeah. I
And
think
you can go.
in our heads, we think what goes up must come down. So
Yes.
it's just that terrifying thought of no, it's got to stay.
I know, and with all that progesterone, patients feel like liquid or something going down, and they think that it's the embryo. So we always try to keep them calm and remind them that it's just, you know, it's just physiological flow, and always the progesterone produces more flow. So the embryo is inside. There's a very long way between the embryo and the cervix.
Yes. Well, do you know what? I was going to end our chat by talking about the transfer, and I might come back to it actually.
Okay.
But I should just because like you were just saying, you just did a frozen embryo transfer, and
Yeah.
you hear a lot, don't you, about fresh versus frozen IVF
Yeah.
transfers. And in fact, you hear fresh versus frozen IVF cycles.
Yes.
Can you explain, like, why? Can you explain what does it? Those that are like, well, what does that mean? A fresh versus frozen? What?
Okay.
Help us understand.
Okay. Yes, I will try. So the thing with frozen is, like, you know, people always think about frozen as a bad thing, because of course we always think, just with food, we always think, okay, this is a fresh fish, this is a fresh meat, it's always better, it always tastes better. So I think that's why in their minds people always prefer to do a fresh transfer embryo, fresh anything, like fresh eggs or fresh embryos. And before, I think the vitrification technique, it was the case because there was the freezing process was using another technique that the most difficult thing is the formation of crystals, ice crystals. So that's why the survival of embryos or eggs were decreased. So that's the thing, because we didn't have that vitrification technique. But since I think it was 2003 where it started, the vitrification is using the liquid nitrogen, and it's immediate. It doesn't use any kind of water. Of course, all the cells contain water. That's why the formation of those ice crystals was so important. But with the liquid nitrogen, the process is so fast and so immediate that they don't even have the time to form those crystals. So since we've been using this technique, the survival rates are increasing very, very much, especially for embryos. I always say it's better to freeze embryos than to freeze eggs, because an embryo is formed by several cells. It's not just one cell. The challenge for freezing eggs is that first, the egg, an oocyte, is the biggest cell of all in humankind. So it's very big. It's highly contained of water. So that's why there was this issue with ice crystals. And now with the vitrification process, the survival is up to 92%. With embryos, it's going up to 98%.
Wow.
Because it's the biggest complex of cells.
And is there a difference in success rates between transferring a frozen embryo and transferring a fresh embryo?
So according to all the papers, all the studies all across the world, there's no significant difference between a fresh embryo transfer and a frozen embryo transfer. So really, this technique is a big advance, and it helps do the transfers of many embryos, because of course you only get one chance to do a fresh embryo transfer, the first transfer after an IVF. But if you have more embryos, your I mean, there's no other way. You have to freeze them.
Yes.
And of course, it also depends on the laws. Here in Spain, you cannot transfer more than 3 embryos at a time. So the first transfer, either it's 1 or 2 or 3 embryos at a time, it's only one shot of doing a fresh transfer. But then if you have more embryos, you have to freeze them.
Yes.
So it's very important to think that it's not a bad thing to freeze embryos or even eggs.
Yes. So if you're going for a frozen embryo transfer, what is the procedure? How far in advance do you, because obviously it won't be as grueling, is that right, as it were the first time round?
Yes.
What do you as a woman have to do, and how long is that process?
Okay, so well, you know, IVF is a process that can last for 15 days. I mean, between 10 and 15 days of this first phase, the stimulation phase. Then you go to the egg retrieval. That's one intervention. It's really not a big surgery, you know, that it's just a small procedure that needs anesthesia, but not a general anesthesia. It's just like a sedation. You're asleep. We use propofol for that. And then it's vaginal. Okay, so there's no open surgery. You don't have any scar, nothing. It can last for 20 minutes at the most, 30 minutes. And so that process is to retrieve the eggs. Okay, and then the lab process starts. We fertilize all the eggs, and then we leave them until the blastocyst stage. So that could be for 5 days or for 6 days. So the 5th day of the embryo development, usually we do a fresh embryo transfer if it's possible. Of course, if the patient had any risk of hyperstimulation syndrome, we do not transfer in fresh. We have to freeze all embryos.
I had.
Oh, you had that?
Yeah, but my IVF. So I have IVF twins who are 13 this year.
Okay.
Back then, I had 2 embryos put in, and then I developed severe OHSS.
Oh, yeah. See, usually it's triggered by the pregnancy. So the HCG is it's what triggers the OHSS.
Yeah.
So when we see any kind of risk, we prefer to use decapeptyl or any other medication to trigger the ovulation before the egg retrieval and avoid the HCG hormone.
Right.
Okay. And not do the transfer because, of course, the HCG is also the pregnancy hormone. So if we do a transfer and it works, well, you get to experience what you did.
Yeah.
And it was it painful? How was it?
Utterly horrific.
Yeah.
Yeah.
So that's
horrific. But I don't know many people that have experienced severe OHSS. Thank God.
yes. Nowadays, it's really not that common. It's very rare because, well, doctors, we don't like to take any risks, any chance to risk the patient's health. So we do not do a fresh transfer.
Yes.
So sometimes when it's possible to do a fresh transfer, we transfer the first embryo on the 5th day if the embryo has developed into a blastocyst stage. If it didn't, we leave it for a 6th day.
Okay.
And if on day 6 they didn't develop, that means that those embryos cannot be used. So either for transfer or for freezing.
Okay.
Yeah. And then, yeah, sorry, I don't know if I answered the whole question, but those embryos can be frozen for as long as you want. I think the longest time that a frozen embryo was for 14 years, and I mean, as far as we know, for today is Yes, I think it was 14 years, an embryo transfer that worked, and well, it was a healthy baby, so that's the longest. So you can freeze it for as long as you want.
Incredible,
Yes.
absolutely incredible. Somebody was asking a question earlier about where did it go? It was quite far up. Are there any negative side effects though? Well, I think from what you've just said, no, any negative side effects from freezing?
Well, the only, I think the only negative side effect, and it's also the worst, is if the embryo doesn't survive the thawing process. That's the biggest issue. But as I said, it's 2% chances. It's very, very low. And it also depends on the embryologist's experience.
Yeah.
Before freezing, you always um, try to classify the embryo, and if you see already there that the embryo is not a very good quality and it will probably not survive the freezing and thawing process, then it's better not to freeze it and not to count on that embryo
Yeah.
right from the start.
How do you defrost an embryo?
Well, I've been to the lab sometimes, so I saw actually the thawing or defrosting process. So it's very, very stressful because they have a timer and they have to, so they pull the straw. They always frozen in a straw. They can be frozen one by one separately or two embryos in the same straw. So they pull it from the nitrogen, the liquid nitrogen. So you see a lot of, you know how.
Yeah.
And then they just put it right there in a media, and it has to pass from several medias. So they have special medias. One that is rich in sugar, glucose, and another one that is all rich in protein. So they have to pass from one to another, and they have the timer. So it has to be 6 minutes in this one, then 6 minutes in the next one, and 3 minutes in another one. That's how you thaw it. And then you leave it in the incubator, and you take a look at it to see how it evolves. So when you just defrost the embryo, they're like compacted, and then you see it 2 or 3 hours later, and you see how it expands and how it gets rehydrated, and it looks just like before freezing. So it's very, very nice, actually.
Then you would then go into the transfer.
Yes, then we go. That's why the transfers have to be later on during the day. They defrost it the same day, but first thing in the morning. So they have all these hours to leave the embryo to get just, to regain the quality and the strength and all the rehydration. And then we do the transfer starting 11, 12 p.m. a.m. Sorry.
Because am I right in thinking an embryo is the size of like a full stop at the end of a sentence? That tiny, right?
Yes, it's really, really tiny. You can't see it. It's you have to see it through the microscope.
Yeah. Embryologists are phenomenal humans, aren't they?
Yes, yes, they are.
Defrosting something the size of a full stop. How? Yeah, it blows my mind.
And they have to do all that, all those, as I told you, they have to leave it from a media to another and act very fast when they just absorb the embryo with a small, very tiny syringe or catheter, and they put it into the other media. It has to be so fast and so quick, and they have to do it looking at the microscope. So it's really, really stressful. For me it was stressful, but to them it's normal. It's what they do. So that's,
like if I have a big meeting or something one day, the night before I have to make sure I go to bed early, and how on earth do embryologists have a life? But I don't know. I don't think I'd want to stay up past 9 p.m. at night.
I know you don't have to, shaky hands. That's impossible. They're very poised and they have to have a very good pulse. So I don't know what they do, but they do it.
Now, listen, talking of lifestyles, there's some questions have come in here that I'd love to just ask. And I should probably put my glasses on because I'm blind as a bat. Al Queenie says, what's some of the best things one can do to prepare for an IVF cycle? She says, if you have, I think she means hectic, because it says here herectic, I think hectic life. What can you do to prepare?
Of course, it's always easy to say, avoid stress, avoid all the anything that can make you nervous, because it releases all these hormones, cortisone and all the steroids. So that's not very good. But as I said, it's very easy to say it, but life is very stressful.
Yeah.
And so what you can do is take anything with antioxidants that kind of balance those steroids and all those toxins that are released from all the stressful life that we have. And so anything with vitamin C, of course. If you are a little bit overweight, try to lose that weight. Eat healthy. Try to do some exercise or anything that makes you feel good, like yoga, meditation, or just go and do your nails. Anything that just have some time for yourself.
Yes, definitely.
Yeah, that's very important.
Acupuncture really helped me.
Yes, acupuncture is something that is very common with IVF. There are some acupuncturists that actually know where to put those needles
Yeah.
for IVF, especially for all the IVF process. So you can definitely use acupuncture.
Yeah. In the end, my acupuncturist also became like my counselor, because and then we just talk, and it's amazing.
Yes,
Yeah.
and that's very important too. Like, have a psychological help. It could be a psychologist or your acupuncturist or your hairdresser or your best friend, but you have to talk about it if you feel the need to talk about it.
Yeah.
Of course.
Yeah, having a good download is amazing. Okay,
Yes.
another question here. Glasses are going on. Ellie says, I'm due to start a frozen transfer in March, hopefully, and I'm not sure what the process will be. What medication will I be required to take, and how long?
Yes. So actually, there are two ways to do an embryo transfer, a frozen embryo transfer, or FET, how we say here. So you can do a natural cycle or a hormonal cycle. So the most common is usually we do a hormonal cycle because it's very safe. It's easier to plan ahead of time, and you don't have any surprises. Both treatments, what they look for is to concentrate on the endometrium, the lining, the thickness. That's the most important thing when you do an embryo transfer. We don't want to stimulate the ovaries. We don't want eggs. We don't want anything to do with the ovaries. We just want the lining to be good. So there are two ways to do that. Leave your natural cycle. So then you have to look at the ovaries, because you leave the follicle, the dominant one, the one that you will have anyways with your natural cycle, to do the job for the lining. It has to produce enough estrogens to have a thick endometrium. It has to reach more than 7 millimeters. So you have to monitor the ovulation. You don't take any medication in the first phase of your cycle until ovulation. So you just have to do ultrasound scans to make sure that the follicle is growing and not to pass the ovulation. That's the risk with the natural cycle. If you already ovulate, then that cycle is cancelled. You cannot do the embryo transfer because you've already produced the progesterone. And that's what's also important in an embryo transfer. That's mostly the progesterone. So once the follicle ovulates, it transforms into a corpus luteus, and that's what produces the progesterone. And 5 days after you do the embryo transfer, if it's a blastocyst stage embryo. Okay, so that's the natural cycle. With the hormonal cycle, right from the start, from the first or second day of your period, you start taking the estrogen. So what's the follicle is supposed to produce, you just take it. So we don't wait for the follicle to grow and produce the estrogens. You just take it right from the start. So that is a little bit safer because you know that you will have the right amount of estrogens, and usually the endometrium reaches that good lining. So we do an ultrasound scan after 10 or 12 days of that hormonal treatment. So usually we use Proginova, for example, and then if we see that the lining is good, the endometrium is more than 7 millimeters thick, we start to give you the progesterone. So we know exactly when you start to take the progesterone, and 5 days after we do the embryo transfer. So that's why I said it's easier to plan ahead of time, because you can extend that first phase with the estrogens as much as you want. It could be 15 days, it could be 10 days, it could be 13 days. If in the first scan the endometrium is not thick enough, you can increase the dose or add some other kind of medication, because usually we do oral. It's like a pill, but sometimes the absorption is not that good, and we also use patches, transdermic patches, and some patients absorb better the medication that way. So there are ways to help if the thickness is not good enough.
Yes.
And then
yes, because somebody's just asked that question actually.
oh really?
Yeah, help increase the lining and the thickness. Yeah.
Yeah. So sometimes we have to increase the dose and change the way of giving you that medication if the absorption is not very good. And then once we see that lining, we start with the progesterone, and we do the fresh the transfer, sorry, the embryo transfer afterwards.
Yes. I've spoken that to a few women though in the past, and their lining really, they could never get to the optimal lining, which is devastating.
Yes.
Common, like, can you pretty much always try and?
No, actually, there are some patients that really have a hard time to get that lining. So usually there are two reasons. The first one is the chronic inflammation of the endometrium. It's called the chronic endometritis. So there is a way to see if that's the problem. That's what is causing that a very thin lining. So we have to do a biopsy of the endometrium and analyze that endometrium to see if there is a chronic inflammation. There is a specific cell that is called CD138 that is causing that inflammation as a consequence. So if we detect that cell, it means that we need to treat that inflammation by giving 2 or 3 kinds of antibiotics, depending on the severity of the inflammation. And usually it's a 2-week treatment. So 2 weeks taking the antibiotics. Usually after that, the lining gets a lot better. And then there's the other cause. It's just, that's how it is. There are some women that never get to that optimum lining. Usually it's also because of the age. of course, the older we get, the thinner is the endometrium, especially after menopause. After menopause, we don't have enough hormones, so the endometrium doesn't have those cycles every month, so it loses its thickness and its capacity to develop, and then you have your period and then develop again. So when you don't have periods anymore, the endometrium, the lining, just gets thin. So now we do have a new treatment with PRP. So it's the plasma rich in platelets that we use inside the cavity to help improve that lining. So there are ways, but it's sometimes it's even with that you don't get to 7 millimeters, but the closer you get to that, even with 6 in some patients that have very, very thin lining, that's good enough.
Yeah. Doesn't it make you think that natural conception is magic?
Oh, yes.
You just think, how on earth does it
happen? I do, because we always think that it's easy. We always think that, oh, you have to be careful not to get pregnant.
Yeah.
You know, as a parent, you always think about that also for your kids. But it's not that easy, actually. And the human fertility is actually the lowest in all animals, if we think of ourselves as, you know, animals. So it's only 20%. And it's getting lower and lower because of all the stress and all the pollution, contamination, and also because of age. The human being is always postponing the pregnancy, especially women. They want to achieve other goals before being a mother. So that's why fertility also is getting a little bit lower. And sperm quality also. It's not always just on women.
Of course. Now there's another question. There's another question here, and I'm conscious of your time. I know you've got to get back.
That's okay.
She says, I have 4 PGT A tested normal embryos. Is it worth doing a mock cycle?
Well, I think personally, I think it's worth it, especially if you don't want to lose that shot of transferring the only embryo that you have normal, right? So it's really not a big deal to do a mock cycle. You do it on your period before the real cycle, and that way you know ahead of time if you are going to react correctly to the medication, if your lining is going to be good, and not just have a surprise the day that you are planning on doing the embryo transfer. Of course, as I said, the embryos are always thawed or defrosted the same day of the transfer. So during the treatment, they will tell you if the lining isn't good. We don't do the embryo transfer, of course. They won't thaw it until the day of the transfer. So the mock cycle will just prepare you psychologically, and also your doctors, to know what to expect. So I'm a fan of mock cycles. I really like to know, you know, how the patient is going to react. Maybe she's not going to tolerate that kind of dose or that kind of medication. She was going to absorb it better with the patches, for example, or vaginal treatment. You know, I prefer to know it in advance.
Yeah.
And then when you do the real cycle, you're just relaxed and you know what to expect. And also for the patient, it's also more relaxing.
Yes. It's like doing a dress rehearsal before the main show.
Exactly. That's it.
Lovely lady who was asking about that. She said she's 42, by the way. And can I have a few months break between the mock cycle and the frozen embryo transfer?
Yes, sure. You don't have to do it right away. because usually, unless something really important happens, like a big surgery or a big emotional shock or anything, it shouldn't change. If you take the same medication the same way, it would work the same way 3, 4, 6 months afterwards.
Yes. Do you know what I've learned from talking to you today is that IVF, when you think about, you know, for those that haven't ever gone through IVF, you think about the process, and you think just these, you know, fairly straightforward stages, but there is so much more involved.
Yes.
So much more involved. It's incredible. It's you just delving in and, okay, that doesn't work, well then we can do this, and that doesn't work, then we can do this.
Exactly. That's actually that's the hardest part of the job, because you always try to find a solution, and even for very complicated cases, you need to find one. You cannot just tell the patient, okay, there's nothing we can do. We always have to find some alternative solution, so we can get to the embryo transfer. That's the goal. Get to the embryo transfer, whether it's your own eggs, egg donation, an embryo donation, or, I mean, the goal is to transfer an embryo at the end so you can get pregnant. And you can find a lot of obstacles in the meantime, and you have to just find the solution.
Yeah. Well, I'm going to end on this last comment.
Okay.
This is this lovely lady saying, I had a mock embryo in between 2 failed frozen embryo transfer. A mock 8.9 millimeters. The frozen was 7. I'm hoping to transfer in March. So we're keeping everything for you, darling. Everything.
Yes. Yes, really, really have the best of luck. So yeah, I mean, 7 is the minimum. If it gets to 8 or 9 or 10, that's always better. But I mean, 7, there's no need to have more. So don't worry. I'm sure it will be a good one.
So do you have any more transfers in clinic today, or was that your only?
No, today I don't have any more transfers. I have more tomorrow, but that's it for today. I have consultations and first consultations also. So let's hope I would give them some answers.
Oh my God, would you hate me if I ask what, do you know, as I was talking to you, a big fox just leapt up at my window. Sorry.
Oh, really? A fox?
Oh, that really shocked me. I know I was about to let you go, but can I just ask you one more question?
Yes, yes, go ahead.
They're leaving people. Okay, Baby from Lab says, can I retrieve and freeze eggs at 42? I'm healing after an operation, and I know each month counts now. I would prefer freezing fertilized. Now you'll have to help me with this. 2N zygote.
Yes.
It's more safe and stable. What do you think?
Well, first of all, you can freeze at any age. Of course, we always say it's better to freeze eggs before 35 years old because of the quality. But then at the same time, any amount of eggs at any age is better than no eggs at all. So if you didn't have the opportunity to freeze your eggs before 42 and you don't think you're going to have the chance to get pregnant now, it's better to freeze them now than never. It's better now than never. That's the phrase. So, just do it. It's also preferable to freeze embryos. I mean, the 2N zygotes. That means when you fertilize the eggs with the sperm, they become a 2-pronucleus cell. So it has the DNA of the egg and of the sperm. So it's a zygote. It's better to freeze an embryo. It's more than a zygote, not just a fertilized egg. It's an embryo that got into a blastocyst stage. So I think if you have to fertilize your eggs with a with the sperm, it's better to leave it and see how it develops until the blastocyst stage, because maybe those two ends cells, they won't transform into an embryo, and you will be counting on something that maybe won't even develop into an embryo. So I prefer to see how the embryos develop, to make sure that the embryos are alive on the fifth day, and then you can freeze them and know the quality and know what to expect later on once you have to use it.
Okay. Your patients are so lucky to have you.
Thank you. Well, I'm lucky to have them too, of course, but I always try to, I think that's what all the doctors in fertility, especially because it's very emotional, as I said. So you really have to have a lot of patience, a lot of empathy, and try to explain things very clearly. So, because it's very difficult. I mean, not everyone understands the two end zygotes and all those, and it's not very easy to explain. So it's very important that the patients understand everything that you're telling them.
Well, also being able to contact you and do things like this is just wonderful. So thank you so much for your time today.
Oh,
and
you're welcome.
By crossing everything for your patient who's left the
Thank you.
with her little embryo, hopefully
Yes. Yes.
and sending love to anybody.
Thank you so much. It was a real pleasure to be with you.
Speak to you soon.
Thank you. See you soon. Bye. Have a good day. Bye.